So welcome everybody to the ongoing the Referral Lecture Series, and today's speaker is Crismale, one of our transplant hepatologists. Unlike what's written on the flyer, Jim has graduated fellowship.
I have?
Yeah.
Okay.
And now he's I think it's a little left over there. So it wasn't my fault.
You get a raise, Jim, or are you still working with the same amount?
See, that's the yeah. See, no one told me. Yeah.
And so we've asked Jim to give us an overview of trying to understand a lot of the sort of terminology and the shifting landscape of UNOS requirements and definitions, and hopefully a little bit of sprinkling of ethics as well, because as you shift certain appeals and requirements, that also shifts the dynamics of fairness in terms of patients getting access to organs.
Yeah, great. Thanks, Gene. Yeah, so we sort of touched on organ allocation and distribution in a couple of different lectures previously, but I really want to frame the discussion today around ethics because it does help to sort of drive how we allot organs to different patients and how we distribute them. So our objectives for today, number one, I want to just really frame this in the context of the ethics of allocation. So we're going to review some of the ethical principles that drive organ allocation and transplant in general, really. Then we're going to touch on how things have changed over time, how the allocation and distribution systems have evolved to better try to attain these ethical ideals. And then finally, just touch on some of the basis behind different MELD exceptions, because again, the way that these have changed, especially the way exceptions surrounding HCC have evolved over time, really has been to try to attain increased equanimity in transplant. So the three main principles that we're going to talk about today are utility, justice, and respect for persons or autonomy. And this balance of utility and justice, and I'll define those in a minute, really are what sort of drives the equitability of transplantation. So this is a couple slides, Philosophy 101. So utility, from a very basic ethics 101 kind of perspective, is trying to maximize benefit with doing as little harm as possible. So trying to maximize what we get out of a limited resource. And this is about balancing, doing good, beneficence, with minimizing doing harm. So base is sort of a do no harm kind of thing. And I think this is illustrated in, again, like an ethics 101 kind of way by the trolley problem. Have you guys heard of the trolley problem? So the trolley problem is when you have some dastardly villain has tied 6 people to railroad tracks, right? 5 people are on one track, 1 person's on another track, and the trolley's hurtling towards the 5 people. So you are an innocent bystander just kind of hanging out, and you see this about to happen. So you, as the bystander, can do one of two things. You can either remove yourself from the situation, do nothing, and let nature take its course, in which case 5 people will die, or you can pull the switch, actively killing 1 person and letting 5 people live. So this is a very morbid way to illustrate the idea of trying to triage a limited resource. And this is kind of a way what we do in transplant. We try to maximize the number of lives saved while minimizing the number of patients who die. So in the real world, the way we assess utility is by looking at outcomes. So we look at things like letting 5 mortality. We look at things like post-transplant survival. We look at survival benefit, so how much additional survival is this person getting by getting a transplant, and we look at things like quality of life, etc. One of the things, or sort of the category of things that we ignore when we talk about utility from the perspective of transplant, and I think in medicine in general, are some of the more social aspects of utility, like what is this person add to society, how much money do they make, how much do they produce. These kinds of things are excluded as a matter of justice. And what justice sort of says is that all patients should have access, fair and equal access to an organ. So this is also known as distributive justice, meaning everyone, no matter where you are, who you are, what your race is, ethnicity, socioeconomic status, everyone should get equal access to organs. And this is, I think in sort of a layman's terms, what we think of when we try to make transplantation fair. We want transplant to be fair for patients. We want everyone to achieve equal access. And we also, as part of this, want the sickest patients to get transplanted first, right? It's more just sicker who have great medical urgency get transplanted first. So this is sort of drives our system of allocation on medical urgency, a desire to fulfill the ethical principle of justice. And these two can sometimes come into conflict. So remember, from a purely utilitarian standpoint, we want to get the most mileage out of that organ as possible. Whereas if we look at the perspective of someone trying to fulfill the ethical principle of justice, we want to get that organ to the sickest patient. So just as a thought experiment, you can think about two patients. They have the same MELD score, same body habitus, same, they're up for an organ, and they basically, all other things being equal, are kind of tied in terms of their MELD score and in terms of, who would get the organ based on their anatomy, etc. One person is really sick, just got out of the ICU, kind of teetering on the edge of whether or not we would actually want to bring that patient to the OR or not. And the other patient is like a 44-year-old guy who has a well-treated HCC, who's capped at 34, who's kind of walking around at home, who's ambulatory, and who looks pretty good. So if I was a pure utilitarian, I would say, well, the patient who is the healthiest now may have the best chance of a good long-term outcome after transplant, so I would want that patient to get the organ. Whereas if I want to give the organ to the sickest patient first, and I want to achieve better justice, I would try to give the organ to the sickest patient, even if that patient may not have the smoothest post-transplant course. So you can see in a very simple way how these things can sometimes come into conflict.
Probably depends on the organ.
Well, yeah, in this scenario, it's perfect, So the other ethical concept that that sort of helps frame transplant discussions is respect for persons. And this is really just autonomy. This involves the concept of making sure that patients and donors are informed about what they're getting into when they sign up for transplant. So in keeping with this principle, we consent all our patients for transplant evaluations. Patients need to be aware of all the processes and rules that go into organ allocation so that they are aware of how organs are going to be allocated and distributed. We need to obtain consent for the use of certain types of donors. So for example, Hep C positive donors or HIV positive donors. And patients have the right to refuse an organ if they, they don't like how it sounds without any penalty. So all of these things are in keeping with respect for persons and autonomy. On the donor side, we have to respect wishes of both deceased donors and living donors. So this is where, we have to respect the wishes of the donor family, for example, and this is something where the organ procurement organization really takes point in their discussions with donor families in trying to attain consent for organ donation. And on the living donor side, we have separate living donor teams so that people who come forward to try to donate a part of their liver are free of coercion. So we try to keep these things separate so that patients are doing this in an informed way and are doing it of their own free will. This is also why you can't pay for organs, can't exchange any goods or services for organs, because this violates the donor's potential autonomy if there's any element of coercion there. Okay, so with those ethical principles in mind, I just want to talk about allocation system has evolved over time, because I think this really illustrates how we have tried to achieve better equanimity in transplantation. So just to define what we mean by allocation, I think Dr. Moon and maybe Dr. Kim touched on this in their talks, but when we talk about allocation, we're talking about how patients are ordered on the waiting list, right? So this is where we have the MELD score, and before that the child score, and we'll talk about how that's evolved. So allocation is how patients are ordered, and then when we talk about where the organs go, so do they go to someone locally, do they go someone to within the region, that's organ distribution. So it's important to just keep that language straight, because it comes up in some of these policy discussions. Okay, so back in the day, before we had child score and MELD score, the way that people got listed for transplant was fairly simple and a little less sophisticated. Basically, patients would get ordered on the transplant list based on where they were. So status 1 was similar to the way it is now, where patients who have a very short life expectancy get top priority. Status 2 were patients in the ICU. Status 3, those who were hospitalized, and 4 were patients who were at home. And then within each of these different strata, patients got ordered based on their waiting time. And as you can see, just sort of intuitively, this is very easily gamed, right? You can easily admit someone to the hospital or admit someone to the ICU and bump up their status. So this isn't the most fair way to allocate organs. So in 1990...
I mean, the other way it wasn't fair. It was that patients who had better access to care, more knowledgeable, savvy doctors got put on the list much earlier.
Exactly.
So it really also disfavored those who had limited access or inadequate access to care.
Absolutely. People who, knew to come in earlier, people who had early referrals would get placed on the waiting list earlier, and then patients who, had no idea and just showed up really sick one day, they got disadvantaged. So in part because of this, in 1998, the Department of Health and Human Services issued a mandate called the Final Rule. And there are a lot of components to this, but the biggest components said that waiting time, as Dr. Freeman said, is an unfair method of organ allocation, and that organs need to be allocated based on who's sickest. So this is where the sickest first policy came in. And the other component of the final rule said that organs need to be shared as broadly as possible, which is something that we're still struggling with, and I'm going to talk about maybe some of the changes to distribution that may be in place that can help us achieve the final rule. So as a way to try to order people in terms of medical urgency, UNOS and OPTN adopted the Child Pew Score to try to help prioritize patients. But I think, as we all know, the Child Pew Score is sort of an imperfect way of doing that, mainly because there's a floor and a ceiling effect. So people with a bilirubin of 4 get the same number of points for their bilirubin as people with a bilirubin of 40. So this isn't a really good way to, order people on a list. It's good at putting people in different buckets and different categories, but that's about it. So you still had these different broad categories based on their child score, based on where they were, and based on some of their complications, but waiting time still played a big factor here, because when you just put people in big buckets like this, there's not really a good way to stratify them. So and this sort of gets back to what we talked about before, where waiting time, when this was looked at, had no bearing on survival, and the main reason for that is just differing times of referral, I think. So you can have someone who's waiting for 70 days and they have a lower mortality than someone who's waiting for 5 days because they just show up later and are sicker when they show up. So waiting time isn't a good metric. So how can we sort of get around that? And this is where the MELD score came in. So as everyone, I think, is aware, the MELD score was originally derived to risk stratify patients going for TIPS, right? So patients who had a high MELD score in the original study, greater than 18, had a higher rate of mortality post-TIPS. Also important to remember, in the original MELD score, the one that was derived for TIPS, the etiology of cirrhosis was included in the model here. So because it was such a good predictor of post-TIPS mortality, the same group applied it to the transplant waiting list to try to assess whether it would be a good predictor of waiting list mortality. And in fact it was. So it was a good predictor of 3-month waiting list mortality, and that was true whether they included the etiology of cirrhosis in the model or not, which is why that eventually came out, and why we had the MELD score that was adopted in 2002 as a way of ordering patients on the waiting list. And really early on, after this was adopted, this had a really positive impact. So early on, there was a reduction in the number of patients registered on the waiting list, because now people aren't scrambling to just get extra time. There was a reduction in waiting time for the same reason, and there was a reduction in waiting list mortality because the sicker patients were getting transplanted earlier. So when we talk about this in terms of our ethical principles, this both increased utility because we have reduced wait list mortality and we have better outcomes, and it also increased justice in the system because now it's fairer. The sicker patients are getting transplanted first. As we know, though, the MELD score on its own didn't capture a lot of complications of end-stage liver disease. It's good at identifying patients who have poor synthetic function, but doesn't really identify patients who have significant complications of portal hypertension, like ascites, bleeding, and encephalopathy. So, how can we add that in an objective way? And this is where the MELD sodium started to come into play. Hyponatremia and cirrhosis develops as a consequence of portal hypertension, right? So as portal hypertension progresses, you get worsening splanchnic and systemic vasodilatation. decreased effective circulating volume, and increased activation of the renin-angiotensin-aldosterone system, and the non-osmotic release of vasopressin, which leads to increased water uptake by the kidneys. So this happens late in the setting of cirrhosis and portal hypertension, and because of that, it's associated with other complications of portal hypertension like refractory ascites and HRS, and it's also associated with an increased risk of mortality. So there was then an impetus to try to incorporate this into a scoring system, and this was done in the landmark paper by Ray Kim's group in 2008, where they found that when controlling for the MELD score, if you have a sodium between 125 and 140, for every 1 point decrease in the sodium level, there was a 5% increase in the risk of death. So using these data, they were able to come up with a model called the MELD sodium score, and then when they applied that model, they found that they were able to better assign around 7% of the patients on the waiting list to higher MELD categories, where they could have an increased chance of transplant. Of course, you don't want to increase priority of patients on the waiting list and sacrifice post-transplant outcomes, right? Because patients who have hyponatremia are sicker going into transplant. They are at risk of having a greater number of post-transplant complications. So this was looked at in another paper a year later, where they looked at a multi-center database looking at post-transplant outcomes with relation to patients' degree of hyponatremia. And they essentially found that 90-day post-transplant survival was similar, and there wasn't a significant increase in the overall group of neurologic or other complications in the setting of pre-transplant hyponatremia. So by adopting this, we have been able to increase justice in the system, again, going back to our ethical principles, by getting organs to sicker patients and without sacrificing utility. So we're not sacrificing post-transplant outcomes by transplanting sicker patients, which is a key component of this score. So this was officially implemented in January of 2016. And now that this has been in place for a couple of years, there's actually data that supports our use of the MELD sodium score. So this is in Gastro, I think, this month. And the punchline of this is that there have been improvements in 90-day waitlist mortality and in the probability of transplant at 90 days among patients on the waitlist in the era compared to the MELD era. Also without sacrificing post-transplant outcomes. And what's important here also is that the benefit is really seen in patients in the lower MELD strata, and that's probably because these patients are sicker than their MELD because they have complications of portal, which is reflected by their hyponatremia. And these results are the same when they did a propensity score matched analysis to control for some other confounders. They essentially found that in the MELD sodium era compared to the MELD era, there was a decreased rate of mortality and a higher probability of transplant on the waiting list. So these, are real-world data that suggests that we are doing the right thing by utilizing the MELD sodium score. So this is more for the fellows just from a practical perspective. Just remember that, so this is our current allocation system. We use MELD sodium to allocate patients on the waiting list. And, when you're on service and when you're dealing with patients where patients are actively listed, remember that there are requirements that patients' MELD scores need to be updated at certain times, right? So if their MELD score is greater than 25, it has to be updated every 7 days. Otherwise, these patients lose, if it's not updated in a timely manner, these patients actually drop down to a MELD of 6 and lose priority. So it's really important, especially when patients are admitted, to stay on top of this, in conjunction with the rest of the team. Okay. So now I just want to turn to talking about distribution and how that sort of evolved over time, again, to try to better get equanimity in transplant. Dr. Moon, I think, touched on this before, but remember, the basic way that distribution goes is from local to regional to national. The reason I'm showing New Jersey here and not New York is, A, I'm from Jersey and Jersey pride, and number 2, New York has always had regional sharing, so we can't use that to sort of illustrate some of the changes that have happened. So just wanted to throw that out there. All right, so early on in the history of the MELD score, it was noticed that patients who were transplanted at very low MELDs, so 15 or lower, actually did worse than their counterparts who weren't transplanted. And that's because they had actually a negative survival benefit. So these patients were dying of post-transplant complications, et cetera. And so this is where a policy called Share 15 came into place, whereby this says that patients who have a MELD score of 15 or lower get last dibs on any organs anywhere. So organs have to be offered locally, regionally, and nationally to everyone with a MELD score of greater than 15 before organs can be offered to anyone with a MELD score of less than 15. And the idea here was to shunt organs to sicker patients and actually to protect patients who had lower MELD scores who may not have benefited from transplant. So the way that this looked, and I'll show you how things have changed even further, is that if you have an organ offer, first it gets offered to status 1 patients throughout the region because these are the sickest patients and these automatically get regional sharing. Then within the local donor service area, or DSA, organs would get offered from a MELD of 40 down to 15. And all these offers would happen within just the donor service area, so within a very localized geographic region. And then once you get down the list to 15, if there are no takers within the DSA, then it goes over to the region, you go down the list there, and then so on, until you have to go down the national list before you can actually come back to the local list and offer it to patients with MELDs of 15 or lower. But what about the other end of the spectrum, right? We have lots of really, really sick patients who urgently need transplant. And if they don't, they're at a very high risk of dying. And the majority of patients who die on the wait list have a MELD score of 35 or greater. So is there a way that we can get more organs to these patients in a more timely manner? So this is where a policy called Share 35 came into effect, which I think Dr. Moon alluded to during his talk, but just to illustrate it here, what this means is that patients with a MELD of 35 or greater have access to regional shares. So someone dies in one particular local DSA, like someone dies up here in North Jersey. If someone has a MELD of 40, it would first get offered within the donor service area, but then if there are no takers with a MELD of 40 in the donor service area, it then gets offered to the region. So this opens up that organ offer to the rest of the region to give the sickest patients getting an organ. If there are no takers within the region, then it bounces back to the DSA where it gets offered to everyone with a MELD of 39. If there are no takers, then it goes back to the region, and then it ping-pongs back and forth like that until you get down to 34. And then once you hit 34, it then just goes down the local list, again, getting offered to patients down the match run from 34 down to 15. And then if there are no takers, then it goes to the region. So this is how it operates in most of the country. Again, in our region, and actually in Region 8, there's already regional sharing, so this kind of thing doesn't apply. We operate as one big donor service area, basically. Okay, so what happened after that? Did this policy make any kind of an impact? So these are data from 2016, which looked at about 2 years of the implementation of Share 35, which went into effect in June of 2013. And essentially what they found is that, yeah, this actually had a pretty positive impact. So under this policy, there was an increase in the number of patients transplanted, and a significant increase in the likelihood of transplant and a decrease in the likelihood of death among patients with a MELD of 35 or higher. So this did what it set out to accomplish, which was getting more organs to the sickest patients. One of the key components, though, also is that there was no change in death or transplant for patients with a MELD of less than 35. So it's not as if you're sacrificing the outcomes in healthier patients in order to serve the sicker patients. You're helping the sicker patients without sacrificing the well-being of the healthier patients. So because of this, you know, if we think back to our ethical principles again, this is increasing justice, right? We're getting more organs to sicker patients without sacrificing utility in the whole system.
So Jim,
yeah.
There's such disparities in terms of the average MELD across regions.
Yeah.
So I'm assuming that the national data probably reflected us only really a subgroup of high MELD regions. Is that right?
Right. So remember, this policy didn't affect us at all because we already had regional sharing. So yeah, I mean, these are national data. So overall, the number of transplants increased, et cetera. But the effect was seen in areas that that didn't have a regional sharing policy in place already. Similar to improved waitlist outcomes, there were improvements in post-transplant outcomes. So these are data that were just recently published this year, looking at 1-year post-transplant outcomes after Share 35 was implemented. And you can see here, so the dotted line is post-Share 35 and the solid line's pre. There was an improvement in 1-year patient and graft survival in the post-Share 35 era among patients who had MELDs of 35 or higher at the time of transplant. And similarly, there was no negative consequence in patients with MELDs of less than 35. So very similar to the data that we just looked at. One of the reasons that we think that patients are doing better in the post-Share 35 era is actually because these patients are getting healthier organs. Because these organs are being shared on a broader level, the average or the median donor risk index of the organs that are being transplanted into sicker patients is actually lower. So this is one reason. In addition to these patients getting transplanted quicker, they're also getting healthier organs. On the flip side of that, patients who have MELDs of less than 35, we're getting slightly ideal organs, but that being said, it doesn't seem to have affected their post-transplant outcomes. So again, increasing justice without sacrificing utility in transplant. Okay, so as Dr. Freeman just alluded to, I mean, there is still significant geographic disparities in the average MELD at transplant. And this is allocation MELD, so this includes both natural MELD and patients with exception points. But you can see here, I mean, in California, the median MELD at transplant is 39 compared to someplace like, the Southeast where you have median MELDs in the 20s. So this is a huge problem, and this in and of itself is an ethical dilemma, right? Because we have really sick patients who are waiting on the wait list. We're just as affected by this as they are out in California, and you have patients with very high MELDs on the waiting list dying on the wait list because there's a disparity in organ availability, and this really just gets down to an issue of supply and demand. We have fewer donors and more patients on the waiting list than some other areas of the country. So there have been multiple proposals to try to change the way that organs are distributed in order to gain increased justice in the system. All the UNOS regions that we have, right? We have 11 different UNOS regions, and within each region there are donor service areas, which are smaller geographic subdivisions. All of these are totally arbitrary. These were all made up. Someone just drew lines on a map, and they're all made up. They have no bearing on population density, socioeconomic status. There's no rhyme or reason to why they exist the way they do, but this has persisted over time. And because of this, this has contributed to some of these disparities, right? So, offers until people go, as I showed before, people go all the way down the waiting lists. So you can have someone, for example, in Pennsylvania who dies on the waiting list, or sorry, a donor who dies here, and have someone who's really sick here, and because we can't cross regional boundaries, that person doesn't have access to that organ. So there have been multiple proposals to try to change this. There have been proposals to break it up from 11 districts into 4 districts, into 8 districts. All of these have been shot down over time, in part because regions and areas that benefit from the current sharing system are reluctant to open things up to a little bit broader sharing. So the most recent proposal, which actually may or may not go forward because there's more sort of afoot here, and further changes may happen where we may see abolishment of the DSAs in the regions. But the latest proposal that has been promulgated is the addition of a sharing circle. So what this is that if a potential donor dies, you draw a 150 nautical mile radius around that donor, and then patients who are within this 150 nautical mile radius can also get access to that organ, even if they're outside of the region. And they actually get additional priority if they wind up within this radius. They get 3 additional points added to their calculated MELD score. So this is sort of a small step to try to expand the borders of the regions. However, if you think about it in certain areas, right, if we go back to the map in California, so Region 5 kind of goes, incorporates multiple states. So if you have someone who's down in LA, you draw a 150 nautical mile radius around this, you're not gaining anything by that. So this policy doesn't really help certain areas that are really in a lot of need. But the idea behind this and the way this has been modeled is that this would make for more equitable allocation MELD at transplant. So this would even out some of the disparity in terms of the MELD at transplant in different regions. So, this is a positive step in the right direction, but many see this as sort of a not going far enough. And there are potential changes, again, that are being attempted to try to get rid of the donor service areas in the regions. So this is an area to stay tuned on, because nothing's really settled here just yet. I think, though, it's agreed that we need to do something to increase broader sharing to make transplant fairer for patients. The folks who say that, this would actually adversely impact certain people, there is some basis to that, in that certain regions actually do benefit from the system as it is, and this includes regions that that have poor access to care and who are at high socioeconomic risk. So this study looked at different counties that have high community health scores. The higher the community health score is, the more socioeconomically disadvantaged the area is, the more people who are on public insurance, lower education level. So these areas actually, when controlling for other factors, have worsened waitlist mortality because they have poorer access to transplant centers, they get referred later, and a number of other factors contribute to that. So there are concerns that redistribution could adversely impact some of these communities. So also from this study, they looked at, this is modeling with a change to an 8-district model. So what they found when they sort of modeled these data are that communities that are at high socioeconomic risk, so that's sort of the darker bars here, communities that are at higher socioeconomic risk would actually stand to lose in terms of transplant volume compared to regions that are at lower socioeconomic risk. So there is something to be said for the advocates of keeping the system the way it is, although if you look sort of globally, keeping things the way they are isn't really realistic, and it doesn't do anything to propagate justice in transplant. So, okay. So shifting gears here, just want to talk about some of the MELD exceptions and how things have evolved over time, especially in terms of HCC exceptions, again, to try to improve justice and utility in transplant. And also for the fellows, just a couple of practical matters about how we actually get these exception points and how these patients get listed. Okay, so as we know, the exception system exists because there are certain patients whose mortality isn't accurately reflected by the MELD score. So we add points onto their score to move them up the list in order to give them some priority. So the ones that I'll talk about here are the most common ones that we see, and those are the ones that are bolded. If you're interested or are bored or whatever, this is all found on the OPTN website. You can go to this URL here, and this has the entire policy document. So if you have a question about a particular patient, about, oh, well, this patient has portal pulmonary hypertension, how do I actually get them exception points? It's all found there. Okay, so I include status 1 here because I kind of think of this as an exception because you are sort of prioritizing a patient differently outside of the MELD system. So again, this is reserved for patients with the highest waitlist mortality. These patients get immediate access to regional sharing of organ offers. So most commonly we use this for patients in acute liver failure, so patients with new onset decompensation, with coagulopathy and encephalopathy without any history of liver disease. In addition to having clinical acute liver failure, however, these patients have to meet certain requirements. So they have to be in the ICU. This is why we're so focused on getting these patients to the ICU. And they have to have at least one of these. So they have to be on a vent, they have to be on CVVH usually, or another form of renal replacement therapy, and they have to have severe coagulopathy with an INR of at least 2. If they don't have one of these, you can still get status 1, but you have to write an appeal to get it. So this is just important to remember from a practical matter. There are other indications for status 1. So if you don't have a liver, you need a liver. So if patients are anhepatic for some reason, they get status 1. Patients also post-transplant who have primary non-function. So you put the graft in and it just doesn't work. They're still in liver failure. Their arteries open. Everything else is okay, but their liver just doesn't work. If they meet these criteria, so if they have an AST of greater than 3,000 plus one of these, then they get additional priority. They get status 1 listing. Also, patients with hepatic artery thrombosis who have liver failure post-transplant, same kind of thing. They have to meet one of these criteria as well, and those patients get status 1 priority. If they get, just as an aside, if they get hepatic artery thrombosis within 14 days of transplant, but not within a week, they can get listed at a MELD-40. So that's another exception. Also remember that patients with acute decompensated Wilson's disease, even if they're not in fulminant liver failure per se, if they come in with new decompensated Wilson's, even if they don't meet criteria for ALF, those patients can still get status 1 listed. Also important from a practical standpoint to remember this needs to be recertified every 7 days, just like patients with a high MELD score, right? So we've seen this before where patients get listed at status 1, they don't get transplanted, but their status doesn't get updated, and they can actually fall off in terms of their priority. So this needs to be updated, just like patients with high MELD scores.
Or it may suggest that the patient doesn't need the status 1.
That is very true, right?
Because they've gotten better, because you expect mortality, to occur at
within 7 days, right? Mm-hmm. Okay. So I'll spend just a few minutes talking about HCC exceptions, because this is something that has really evolved over time and is still evolving to try to achieve better equitability, especially among patients with HCC exceptions and without. So, prior to the adoption of Milan criteria, outcomes for patients who got transplanted for HCC were pretty poor, with a 5-year overall survival of less than 40%. But then in 1996, Mazzaferro and his group defined the Milan criteria as patients who were at low risk of recurrence post-transplant and, those who could do well after a transplant. So as we know, these are patients with 1 lesion less than 5 centimeters or up to 3 lesions less than 3 centimeters each. And so when the MELD score was adopted, this was utilized as a way to identify patients who should get additional priority. And I think it's important to remember that the priority that these patients get is not to reflect necessarily their mortality on the wait list, but it's to reflect their risk of dropout. So these patients will drop out of the wait list when their tumors expand beyond Milan. So that's sort of the idea behind adding exception points to these patients. It's not that we necessarily expect them to die on the wait list, it's that we expect their tumors to get too big and for them to drop off the wait list. And so with this, there was a MELD elevator assigned, right? So every 3 months, patients would get additional points based on an estimated 10% increase in their dropout risk. So this is sort of an overview of how things have evolved. So early on, patients were assigned 29 points when they got on the wait list. And a lot of these patients got transplanted immediately. So early on, this was seen as, you know what, we're over-prioritizing these patients. We need to drop the number of points that these patients are being assigned. So subsequently, it's dropped to 24 and then 22. And then it was that way for a long time, where patients would get 22, then 26, then 28, then 29, etc. And then I'll show you some data about why we've now gone to sort of a delay where we don't assign points up until 6 months, and a cap system. The cap is really there so that patients don't enter into regional sharing with with share 35, right? So they get capped at 34, and because if they then continue to go up the MELD escalator, these patients would get access to these regional organs, which we're trying to conserve for the sickest patients. So these are data from 2012, so before the cap and delay system was put into place, where they essentially just looked at what the patient's risk of death or dropout for being too sick on the wait list is, comparing patients with MELD exception points and those with natural MELDs around the same range. So as you can see here, going from a HCC MELD of 22 to 25 to 26, their risk of waitlist dropout or death is pretty stagnant. Compared to patients with natural MELDs who go up like that, their risk of waitlist death or dropout significantly increases with time. So these data suggest that, sort of routinely elevating these patients' MELDs does not accurately reflect their risk of death or dropout. And sort of just to illustrate this, they looked at, what's the risk of someone who has a HCC MELD of 22 dying or being removed from the wait list within 90 days. It's around 4.1%, which is equivalent really to someone with a natural MELD of 15 to 16%. So sort of proof that, early on during this era that we were over prioritizing these patients for transplant. Similarly, when we compared patients who got transplanted for HCC in short wait time regions and long wait time regions, so regions 3 and 10 have very short wait times. You get listed, if you get 22 points, you may be up for a transplant, in a couple weeks. Whereas in regions 5 or 9, that's us and California, there's a long wait time, right? So in patients who were listed for HCC, they looked at post-transplant outcomes and found that post-transplant outcomes were actually better in long wait time regions. And the reason for this is that patients in short time regions may have been getting transplanted with aggressive tumors and then had recurrence afterwards, leading to decreased post-transplant survival. So patients for whom we had a chance to observe the tumor biology, see if they would progress beyond Milan, those patients wouldn't go to transplant and would die on the waiting list or drop out. So we had a chance to sort of observe the natural tumor biology. And this is what gave rise to this idea of delaying the assigning of exception points so that we can observe tumor biology over time. So this is still in flux because there are still data that suggest that even with this, we are still over-prioritizing patients with HCC. So the most recent proposal for this is actually doing away with the MELD escalator altogether, still having a delay, but then just assigning these patients their median MELD at transplant -3. So the median MELD at transplant within the donor service area, which would get recalculated every 3 months, -3 points, and then just sort of leaving patients there. So, this would certainly deprioritize some HCC patients, especially in an area like ours where the median MELD at transplant is relatively high. But this is sort of a one-size-fits-all kind of approach, and so there are some that would advocate for some more dynamic assigning of different points, so it'll remain to be seen. I mean, this is supposed to go into effect later this year, so we'll see how things go. Yeah?
I had a question about, so you have a patient that has HCC and that at some point while they're getting surveillance scans, they fall out of one criteria, and then you have to downstage them. How does that pain improvement? Like, do they get status 7 and how does that affect?
Yeah, so they get treated and they get downstage, and then I believe they have to remain status 7 until their next scan, at which time they have to. But then you have to appeal them. Yeah. So if they have a standard MELD exception where they were in Milan initially, and then they fall out, then that has to go to the National Review Board for an appeal. So I think it'll depend in large part. It'll vary depending on the review board, whether they would keep the points or not. But I think the patient would be made status 7 until the patient gets downstaged. And then what they wind up with in terms of their points afterwards would depend on what the review board said, because then it comes out of the standard exception and goes to the appeal. Okay, so we'll spend a few minutes just talking about some of the non-HCC exceptions that we see pretty frequently. So the two most common ones I think that we see are hepatopulmonary syndrome and portopulmonary hypertension, but all the rest of these actually have standard exceptions for which you can get additional points for patients. And all of this is in that OPTN policy document, and I can send that around to the fellows if you guys want. Okay, so not to spend too much time on this, but hepatopulmonary syndrome is a condition that develops in the setting of portal hypertension, where you get dilation of the pulmonary vascular bed, which leads to shunting and VQ mismatch. And the way that this is diagnosed is that patients can't have any underlying pulmonary disease. They have to have evidence of impaired oxygenation, have to have evidence of portal hypertension, so ascites or varices, and have to have evidence of a shunt, either on bubble echo or on macroaggregated albumin scan. So this is how the exception has to be submitted, just again for practical purposes. So again, patients have to have evidence of portal hypertension, they have to have evidence of a shunt, and they actually have to have a room air PaO2 of less than 60. So all these patients need an ABG in order to identify this. And again, they can't have evidence of underlying pulmonary disease. And then when you list these patients, they all get assigned a MELD score of 22, and then they go up by an increment that's equivalent to a 10% increase in their mortality every 3 months. So these patients also have a MELD escalator. And this is important because these patients are at higher risk of waitlist mortality if they don't get exception points and if they don't get transplanted. So these data are from a paper from 2005 where they looked at patients with hepatopulmonary syndrome who underwent transplant and those who didn't. So you can see here the survival for patients who did not undergo transplant but who had hepatopulmonary syndrome was quite poor compared to patients who underwent transplant. The sort of exception to this is patients who have severe hypoxia at the time of their listing. Patients who have a PaO2 of less than 50 at the time of their transplant actually may do less well than and may have poor survival than other patients. But there's concern, again, as with other exception points, that these patients may be getting over-prioritized. So this is a paper by Dave Goldberg's group where they looked at the UNOS database looking at rates of waitlist mortality and transplants for patients who had hepatopulmonary exception points. And what they found is that some of these patients are being over-prioritized. So in looking at patients with hepatopulmonary syndrome exceptions, there was a higher rate of transplants and a decreased rate of waitlist mortality compared to patients with equivalent natural MELD scores. So this sort of drives home the point that we want to use exception points to make it fairer for patients whose degree of illness isn't reflected in the MELD score. But at the same time, in doing that, occasionally some of these patients get over-prioritized. So these data call attention to that issue. Portal pulmonary hypertension is our other sort of lung-liver axis condition that we can get exception points for. Remember, this is when essentially pulmonary arterial hypertension occurs in the context of portal hypertension. It gets diagnosed just like you would diagnose pulmonary arterial hypertension with a high mean pulmonary arterial pressure and a low pulmonary capillary wedge pressure. And this is a very morbid condition because the 1-year survival of patients without any kind of treatment is very low, so 35 to 60%. So this is why when patients are identified with this, we need to really involve our pulmonary hypertension colleagues and get these patients on medical therapy. And while transplant can be curative in some cases, there are data that suggest potentially worse post-transplant outcomes in these patients. So these are the criteria for listing patients with portal pulmonary hypertension. Again, they have to meet all the hemodynamic criteria. I won't go through it, but it's all here in the policy document. And then these patients get a MELD score assigned of 22, and then they go up the escalator as long as they continue to meet criteria. So this is another paper by Goldberg's group where they looked at the impact of MELD exceptions for patients with portal pulmonary hypertension. And contrary to some of the other exception points that we talked about, these patients are actually less likely to be transplanted and more likely to die on the wait list or be removed for being too sick. Again, speaking to the significant morbidity and mortality that can occur with this condition. And actually, looking at overall survival, so including pre- and post-transplant survival, these patients overall did worse. So this may argue sort of in the other direction for, should we be prioritizing these patients if they wind up having worse post-transplant outcomes? There are a couple of non-standardized exceptions that I won't spend too much time on. The one that we see probably most commonly is recurrent cholangitis. So we assign exception points for these patients because many of these folks have a well-preserved liver function with a well-preserved MELD, but they're at risk for waitlist dropout or death because they get recurrent infections, they get multi-drug resistant infections. But this only occurs really in a small subset of patients with PSC. Only around 10% of patients get true recurrent multi-drug resistant infections. So the initial consensus guidelines for assigning exception points for these patients were, you had to have at least 2 episodes of culture-proven bacteremia within the 6-month time period. Again, work has been done to look at whether these patients are getting excess priority. So this was again taken from a study looking at patients at Penn and UC Denver, where they compared patients with PSC with cholangitis and without cholangitis on the wait list and assessed their wait list mortality. And they found that when controlling for their MELD score, there was no difference in mortality on the wait list or dropout for patients with cholangitis or without cholangitis. Again, sort of calling into question excess priority for these patients. So in part because of this, the most recent guidance is on assigning exception points for these patients is much more stringent. So patients have to have at least 2 episodes of cholangitis that have landed them in the MICU with pressors over a 3-month period. So a much more stringent set of criteria. And then they also have to meet one of these other minor criteria. So they have to have a stricture that's unresponsive to treatment, and they have to have been diagnosed with some multi-drug resistant organism. And then they actually assign the median MELD at transplant within the region. So this has become a little bit more strict, and this is probably what we'll see when we go to the National Review Board in terms of who they'll allow us to assign exception points for. So the overall impact of a policy like this still, I think, remains to be seen overall. Okay, so just to wrap it up, covered a lot of ground. So we talked about some of the ethical principles that sort of undergird transplant and organ allocation. We talked about how these things have evolved over time to try to help better attain some of these ethical principles. We talked about some exception points, and we also touched on some of the potential changes to the distribution system that are coming down the pike, hopefully to make transplant more fair. So that's it. Thanks.
Thanks, Jim. That's an outstanding overview. Questions? So, Jim, I have a question. So, one thing that's striking about the sort of modern MELD and organ allocation is that it's a pretty linear curve in terms of survival to try to transplant the sickest first as the MELD score rises until you get to about 35. Right? So, at 35, that slope starts to come down. So, it suggests that the utility of transplant patients who are the sickest of the sick starts to go down at that point. And so, we cap the MELD score at 40 to sort of help with that. But I wonder what your thoughts are on that, and also with the idea of frailty, for example, as sort of the hot new thing that may be the next sort of MELD sodium.
Right. Yeah, so, there's this concept of utilizing a metric like survival benefit, where you're looking not only at what the patient's waitlist mortality is, but also at what their likelihood of having a good post-transplant outcome is. So I think that speaks to the idea that, when you have really, really sick patients, they may not do so well post-transplant. And so, is there a way that we can incorporate that into our allocation system? I think, from a utilitarian perspective, it makes a lot of sense, right? You want to get the most mileage out of these organs. From a perspective of, trying again to maximize things like justice and balance that, you want to give everyone a fair shake. So I think that's something that, I think is up for debate. Regarding frailty, that's obviously a strong prognostic marker, but it's also a poor marker of poor prognosis post-transplant, right? So this sort of would factor into that as well, I think.
All right.
Super.
Thanks.
Great work.